Hello, and welcome to this podcast episode. Today, I want to talk about what happens to the meaning of work when a robot enters a healthcare setting. I spent weeks observing this in a nursing home, two hospitals, and private clinics in southern Spain. And what I kept seeing was the same pattern. A mobile telepresence robot arrives with genuine promise. It can connect a specialist in the city to a patient in a rural clinic. It can free a nurse from repetitive tasks. It can extend care to people who would otherwise go without. And at the same time, almost invisibly, it begins to touch something that nobody thought to protect: the small human moments that make healthcare work feel worthwhile. Mobile telepresence robots are remotely operated devices wheeled with a screen and a camera that allow a healthcare professional to be present in a room without being physically there. A specialist in one city can navigate the robot through a clinic in another, see the patient, speak with them, and conduct an initial assessment. The robot becomes their presence in the room. But before we get to the robots, we need to understand what meaningful work actually looks like for healthcare staff. The research identified 3 dimensions. The first is connections, bonding with patients. Being the person someone vents to at 2 in the afternoon when they're scared or lonely or frustrated. One healthcare worker described it this way: on the event with us there, I feel very useful being able to help in that aspect and transmit tranquility. And that the event, for me, is very gratifying. For staff at the nursing home especially, connections also meant engaging with residents' families. The conversation when a family member asks how their mother is really doing. The second dimension is contributions. Seeing that your work changed something tangible. A patient who came in unable to walk properly and leaves stronger. Pain that is gone. An improvement you can actually witness. The third is recognition. A patient who hugs you when their treatment ends. A family member who catches your eye and says thank you like they mean it. A small gesture that tells you you were seen and it mattered. 3 things: connections, contributions, recognition. All of them, in some essential way, dependent on being physically present with another human being. Hold that thought. Now let's talk about the opportunities these mobile telepresence robots presented, because they were valuable, and the people I'm describing were not dismissive of them. The use case that generated the most excitement was reach. A specialist based in a major city could assess a patient in a rural clinic without either person traveling. Physiotherapists saw a way to show patients exercises remotely useful for patients who needed guidance, but not hands-on manipulation. Some staff imagined using the robots for initial assessments in emergency settings where the right specialist wasn't physically present. But every one of those opportunities had a paradoxical effect. One clinician described the threat in terms that went beyond logistics. She said, "It makes me think that it is not necessary to be directly with the patient, and that attacks a lot of what I believe in, because I really feel the face-to-face contact, looking at their faces and humanizing the care, is what gives me the most satisfaction." For physiotherapists, the problem was even more fundamental than philosophy. Touch is how they build trust. One was direct about it. They do not trust you if you do not touch them. If I have a session and I do not touch the person, that patient looks at me strangely. Then there was something more subtle, and I found it one of the most striking findings in the study. Nursing home staff described tasks they found tedious, things like overseeing video calls between residents and their families. They didn't enjoy doing it. But here's the thing, even those calls created meaningful moments. A family member would lean in and ask how their relative was really doing. A moment of recognition, of connection, that happened precisely because the staff member was there. One nurse said it plainly: being able to bring each patient closer to their family filled you a lot, with moments that you had to live and listen to because you had them in front of you, but now that will be over. And there was also concern about the residents themselves, older adults who might find the presence of a robot unsettling or distressing. Here's where I want to slow down, because this is the heart of it. A specialist in one city can use a robot to reach patients in a rural clinic with the possibility of doing night rounds and move around the clinic. The robot makes the consultation possible. That is a genuine opportunity. And at the same time, the specialist who used to walk into that patient's room, place a hand on their shoulder, and build trust through physical presence, that interaction is now mediated by a screen. The patient sees a face. They do not feel a hand. And for many healthcare workers I spoke with, that physical presence was the foundation of the therapeutic relationship. The same technology, two consequences, simultaneously. I call this the paradox of distance and proximity. The robot brings a specialist closer to a patient on one side of the country, while creating distance in the room where it stands. It expands access and contracts intimacy at the same time. And neither of those things cancels the other out. So how did people navigate this? Because what the study found next is, I think, the most practically useful part. Healthcare workers did not simply accept the robots as delivered. They wanted to innovate and bend them toward what mattered. Healthcare staff envisioned robots with autonomous navigation that could move through the facility without supervision, and they imagined facial recognition to locate specific residents. Physiotherapists suggested recording exercise instructions to play on the robot screen while they went to check another patient. Hospital staff envisioned using the robots for initial assessments, saving the in-person visit for the stages of care that really needed it. None of those features existed in the robots at the time of the study, but the staff were already there in their minds, shaping the technology toward what mattered most to them. But that creative energy needs somewhere to go. And the study was clear: without the right organizational conditions, it goes nowhere. My study found 4 key elements need to be put in place so that healthcare staff can utilize mobile telepresence robots in innovative ways to foster connections, encourage contributions, and promote recognition. First, the robot must work seamlessly. If someone has to babysit the robot while also trying to provide care, the robot has become another problem, not a solution. Second, the infrastructure has to actually be there. Wi-Fi throughout the facility, every room, every hallway. Dedicated quiet spaces for video calls, because older residents with hearing difficulties cannot communicate effectively in noisy shared spaces. And integration with healthcare IT systems, so that scheduling and records connect to how the robot is actually used. Third, real technical support. Easy to use and available when things go wrong, especially if they go wrong in front of a patient or a family member. That moment of fumbling with a malfunctioning robot erodes trust fast. Fourth, training. Real courses, real protocols, time actually set aside to learn, even if it means temporarily stepping away from care duties. Staff who are confident with the technology are staff who can push it in creative directions. Staff who are not are just managing one more stressor. The study's conclusion is that the threats that mobile telepresence robots pose to meaningful work, the erosion of face-to-face time, the disappearance of incidental human moments, cannot be fully eliminated. But meaningful work can still be preserved and promoted if the right structures exist, and if staff are genuinely given the agency to adapt the technology to what matters. Structure creates the conditions. Agency creates the possibilities. Let me close with the thing I keep coming back to. The same technology that connects can also distance. That is not a flaw to be fixed. It is a paradoxical tension that has to be managed deliberately, thoughtfully, with the people who do the work kept at the center of every decision. The healthcare workers in this study were not anti-technology. They were pro-meaning, and they wanted to keep the things that made their work feel worthwhile, and they were clear-eyed about what those things were: being present, being trusted, being recognized, watching someone get better. When they saw a robot that might take some of those things away, they felt it. And when they saw ways to use the robot to protect or extend those things, they imagined them sometimes more creatively than the designers had. That creativity is a resource. Organizations that treat it as such, that invest in infrastructure, training, and true staff involvement, are the ones most likely to navigate this well. The answer is not robots or humans. It is thoughtful implementation with staff at the center and with honest acknowledgement of what is being asked of them. Thanks for listening. Until next time.